Life is the most precious gift we are given as human beings. But life is a gift not promised to last forever. It requires care and diligence to live a happy and healthy life. It requires good health care to live a healthy life. The decisions we make today will directly affect the quality of our lives and shape the future for our loved ones. I would like to have a discussion about healthcare. I want to help you get to the truth. My name is Mike Harris, and I have been a professional healthcare provider for more than 20 years. Let me share my knowledge and insight with you as we strive together to live a longer, healthier life. Welcome to the Nurses Station. We're welcoming Yvette Simmons, nurse practitioner, onto our show. She's going to be talking about why nurses don't speak up for themselves. Yvette, you want to introduce yourself?
Well, my name is Yvette Simmons, and I'm a nurse practitioner. I have a master's in adult health. And first of all, I want to thank you, Mr. Harris, for having me on your show today. I'm very excited.
Absolutely.
I also would like to say that since I was a child, I always enjoyed medicine, and I always knew that I was going to grow up to be a nurse. I always liked caring for people. And so I pursued that career, and I'm very, very happy that I became a registered nurse.
Yeah.
So I went to school at City College in Harlem in the 70s. And I graduated from City College with a Bachelor's of Science degree in nursing. And then later on in 2003, I obtained a master's in adult health, and I became a certified registered adult nurse practitioner. I went to Long Island University in Brooklyn. My work history is basically my first job as a registered nurse. I worked at Hospital for Joint Diseases.
Yeah, well, that's where we met.
Yes.
That's right.
And so I stayed there a few years, and my passion was public health. And I did a little bit of visiting nurse work. I worked for the Visiting Nurse Service of Brooklyn. I worked for the Visiting Nurse Service of Association, the VNA of Brooklyn. And I did some private duty nursing.
So now the Association of Nurses, how does that
Well,
work with
it's
Visiting Nurse
two
Service?
different organizations. You have the Visiting Nurse Service, and at
Right.
that time, there was another organization called the Visiting Nurse Association. And they provided field visiting nurse services for patients who were homebound.
Okay, so they had to strictly be homebound.
Yes.
And now Visiting Nurse Service, what do they cover? Acute care to chronic care and all in between?
They provided the same equitable type of service, whether it was VNA or VNS. Any patient that was discharged from the hospital,
Yeah.
they were given home care services where, let's say, for example, if a patient was discharged from the hospital, they would be followed upon admission to discharge by a discharge planner within the hospital setting.
Are those nurses or they are different?
They are supposed to be nurses. They should have some degree of nursing background to plan a patient's discharge from the hospital.
Right.
They should be assessing upon admission what are their needs and what are their future needs upon discharge. So if it's a diabetic that was diagnosed in the hospital, perhaps that patient would need diabetic teaching at home, teaching them how to pre-fill their insulin syringes or teach them about their medication regimen to help make sure that they're in compliance with taking their medications and eating a proper diet to maintain their blood sugar level. So
Right.
The discharge planner would make their initial assessment of the patient, take a history, and follow them throughout their hospital stay. And upon discharge, perhaps this patient lives alone, they don't have any significant others to take care of them at home. So they would basically send a visiting nurse initially into the home, and that visiting nurse would open the case and find out what that patient's needs are. Do they need a home health aide to help them assist with meal preparation? Do they need a visiting nurse to teach them diabetic teaching, pre-fill their insulin syringes? Maybe this diabetic patient
Right.
cannot see.
So basically, we're going to go back towards the initial reason on why we're here with the nurses not being able to speak up for themselves. Well, in the hospital setting in which we met, we had different levels of administration. We had different areas of nursing in which we worked. But we particularly worked in orthopedics at that time, and that was when the Hospital for Special Joint Diseases moved from Harlem and was continued to be called the Hospital for Special Surgery, Orthopedic Surgery, and then was renamed Uptown in Harlem, North General. Now, why do you think nurses at this time do not speak up for themselves?
Well, throughout the over 30 years that I've worked as a registered nurse, I strongly believe that it's an intimidation from administration. When a nurse has a
Is there a
complaint-
particular administration that you're focusing in, and is it like the financial portion, or is it the nursing portion of administration?
I think it's a labor issue. For example, if a nurse is assigned 1 to 16 patients,
Whoa.
which during the 1980s I worked on a unit at Hospital for Joint Diseases, and I was assigned 16 patients
Jesus.
to my one. And having said that, if I felt uncomfortable about accepting the caseload at 16 patients because I felt that I would not be able to give the quality care or to keep the patient safe, because again, you're dealing with a multitask function as a registered nurse. You're giving out medications, you're also checking doctor's orders, you're also doing a lot of bedside care nursing. And I don't want to negate that fact that hands-on nursing is why I became a nurse.
Yeah, hands-on
not
is
just-
a great deal. You're getting doctor's orders that need to be filled, and it has many orders on them for one individual patient for a multiple diagnosis. That I do know, as well as the initial reason for admission.
Yes.
So now, how have you seen that trickle down from 16 patients to what now?
Well,
Before you started your own practice?
yes, well, I still feel that the patient ratio is still a problem. It's a problematic issue in most hospitals and nursing homes. So I don't see the patient ratio problem going away. I still believe that a lot of the nurses are overloaded with patients that are assigned to them. And every patient has different needs. And I find it a safety issue. You may have patients that are bedbound and they are incontinent. You may have a patient that's on an intravenous therapy. There are many haphazards if you over-assign one nurse. If they're overloaded with these cases, it's an open door.
So do you think that
for malpractice?
Right. So I'm listening to you. Do you think one of the reasons nurses don't speak up for themselves would be because of that? They've run into many accidents or problems, and they fear the retribution of that.
I believe that nurses feel that there would be some retaliation.
Okay.
Some nurses feel that they don't want to be portrayed as a bad nurse, as a disgruntled employee, as a lazy nurse. And I think that when...
Or not a team player.
Yes. And I think it's our responsibility as a registered nurse to first and foremost protect the patient's safety. We are patient advocates, and as well as being wise, because if you see that your license is going to be in jeopardy by not being able to take care of 16 patients to one, it's prudent of the nurse to express that to the nursing supervisor on the floor and ask for assistance at least. Make a note to memorialize it.
So more or less a protest of assignment
Yes.
that needs to be
Yes.
reviewed by administration. But does that work?
No, it doesn't work most of the time, because when a nurse is notifying a nursing supervisor on the floor that they're asking for more help, what happens is the nursing supervisor's job is linked with management. And the nursing supervisor's job is to basically get the job done, and later we'll talk about it, but the problem is never resolved. And I believe that the nursing supervisors now should also act in alliance with the registered nurses who are telling the nursing supervisor what they need. Give the registered nurses the tools in which to maintain a quality, dignified, skilled nursing care for each individual patient.
Right.
Otherwise, what's going to happen, and you hear it all the time, sometimes there are medication errors,
Multiple.
registered nurses injure themselves, nurses are overworked, the sick call rate increases, and
Right.
I believe it's important that the CEOs and the hospital administrators are informed by the nursing supervisors or have a regular meeting at the end of the week. There should be weekly meetings with the CEOs of the hospitals, with the hospital administrators.
I always
inform
say-
them of what is happening.
I agree. I always say
On the
that they're not
nursing
talking to
floors.
nurses because
And-
there's
and-
way too many
Yeah,
accidents.
and it's
Yeah.
important for the public to be aware of it.
Mm-hmm.
And the public is paying a price for it, because the emergency rooms are overcrowded. There's
Yeah, I worked many years in the emergency rooms.
it's very time consuming,
difficult.
having patients waiting for hours, and it's all as a result of the lack of staffing.
Well, do you think that nurses are being utilized appropriately? For instance, there's an overflow of nurses looking for jobs. I have a stack of applications just to work in home infusion with me. And it seems to me that these nurses are not being trained in the first place to at least do the job that they graduated. They passed boards, they graduated, and was able to pass boards. They're now not being precepted or learning a skill to help other people, help their families, help themselves. I'm looking more towards nurses being educated outside of institutions, because it seems like it stops. It's like every nurse feels that they have to go to a hospital to be trained. Do you think that's realistic?
Well, I personally believe that preceptorship is crucial in order to get that registered nurse familiarized and well-oriented to the work environment at whatever particular hospital they're working or whatever nursing home they're working. I think is very important. Every institution has different policies, and they should understand the policies within the institution, as well as familiarize the nurses with all of the resources that they need to carry out their function on a 7 to 3 shift, or 11 to 3 a.m. or 3 to 11 shift. It's good to buddy up with nurses that are already experienced in an institution that's worked within that institution for 6 to 10 years, and that way you develop a trusting relationship and you learn. That's how I learned. The preceptorship that I worked under was fantastic. I think I had at least 2 to 3 weeks, which is unheard of now.
Right.
In the year 2013. There is,
I think it's like they'll orient you for 3 days, and they throw you
Yeah.
into a unit, and then in that unit, you're given like a list to hunt everything, meaning the IV section,
Yes.
the medication section, and be able to understand those areas. But then you're and the computer system now,
Yes.
and then orient yourself to the unit. But how effective is it when you're a new graduate and you don't really understand whether you have a bachelor's degree in nursing, associate's degree in nursing, or a master's degree in nursing, and you're newly oriented into this institution, and you're only given 3 to 5 days?
Yeah.
Is that
That's not a sufficient amount of time to allow this new registered nurse or this new graduate to be independent enough to deliver their skilled nursing care to that patient. I think that we should go back to the old method, which is to give them a sufficient amount, but
3 months, 6 months?
Sure.
Yeah.
The problem is that the hierarchy within these institutions, they're looking for minimal cost, they're paying for cheap labor, and they want
Cheap labor?
quick, yeah, what I'm referring to is they're looking for quick turnover of admissions and discharge to stimulate revenue, as well as they really don't want to spend too much money even on precepting the nurse. They want as quick, fast to get you on the unit so that you
Right.
can be functional and carry out the nursing test. But from within, looking at our Nursing Practice Act, you must be prudent. You have new technology on the floor in the nursing unit. Things are computerized. During the time that I was a registered nurse in the 1980s, we didn't have computers. We didn't have...
No, we did not.
We didn't have prepackaged dosage medication.
Right. We had to mix that
pre-pour. We had to mix.
Right.
We had to stand there in intravenous line
and count.
and count, look at what your watch and count the drops.
Right.
But now things are more connected to wires and computers.
Which in a way, for me, is very good, because in home care, I like this whole Skype issue where I can key into a professional like yourself, and we can advocate for that patient in a more effective way.
Yes.
Definitely, the disease process comes out
Yes.
clearly when you have someone to
But
work
I
with.
want to stress that, getting back to the intimidation factor of why nurses don't speak up. Again, I like to emphasize that nurses are most uncomfortable because they don't have an alliance of other coworkers as well who will support them.
Why do you think that is? Do you think it's, for me, I thought it was cultural.
It is also cultural. You have some nurses that are from other countries, which we welcome. However,
Right.
they,
Very
from
much.
some of the countries that they come from, particularly Philippines, I've been to the Philippines, I've been to Australia, I've been to some of the Caribbean
We have to have a
countries.
conversation about that.
Yeah, and a lot
been
of
to the
the
Philippines.
nurses that I have spoken to from the Philippines, they lack the comfort. They don't have the comfort in approaching administrators, approaching their nursing supervisors and saying, hey, you know, I think 16 patients, I think it's dangerous for the patient's safety, not for my security. And then also, I don't want to have any room for any lawsuits, because if there's a medication error, this is dangerous.
I think that nurse-patient ratio is 7 patients, which I think is a lot to one nurse.
Yes, and I think it's our responsibility to keep verbalizing these danger risk factors in the hospital. I think it's important not to just report it to the nursing supervisor, but I don't want to imply that nurses should neglect their patients, because again,
that's
complaining
another
to the
topic.
nursing supervisors, some nurses feel that they don't want to be viewed as abandoning their patients or neglecting their patients.
Now, abandoning your patient, especially with the law stating that you can quit your job at any time and they can come walk onto a unit and fire you at any time, is that realistic that a nurse is abandoning? I mean, how many lawsuits are there? We need to do some research.
Most of the
on that.
lawsuits are correlated with medication errors. It could be patients who have fallen out of bed. It could be that patients have decubitized.
Decubitized is a big deal.
Where,
yeah.
again, that's another issue. There are patients that are bedbound and they need to be turned every 2 hours. And perhaps you have a scenario where you have a nurse to 16 patients.
Jesus.
Well, the question is, how often can that nurse timely,
Wow.
consistently go in and turn that patient every 2 hours?
It's not realistic at all.
We want to.
I want to bring a scenario to you. There's a recent scenario, and then we'll move into the next question. There was a recent scenario where this patient decompensated and ended up on a respirator. And of course, the peep was like in the teens, and the tidal volume was diminished. And this particular patient, when I looked at them, prior to being intubated, needed to be intubated. And once that patient was intubated, I asked the question to a nurse, and I'll ask it to you. Now, you have that scenario. You're on a general floor. It's not a specialty floor. And after that particular patient is intubated and is still on this particular floor, med-surg unit, and I ask you, and you're the med-surg nurse, and I'm going to ask this question. I want to see how you can answer. When you turn this patient over, in report, what type of nurse are you giving your report to? Is it going to be an ER nurse or not?
It's going to be a nurse that is highly skillful. It's going to be a specialist. It's going to be a nurse that comes from a specialty area.
Right.
Because if this patient is left on a general nursing floor, this patient needs more high-tech monitoring, supervision. And if you're busy on the unit of a med-surg floor, this patient should be in a location where this is one-to-one.
Well, the answer that was given to me, and this is not to downgrade the nurse. This is to educate the nurse. When I say this is to make sure that this particular nurse understands that it is teamwork, not just your answer. That if you don't know, to ask someone, maybe I should ask who that person is going to be. Because the nurse answered it this way to me. She said to me, well, we do everything here. And my only response to that was, well, would you think it best to make sure that that particular nurse has the specialty to handle this particular event, to lay the patient as an ICU respiratory nurse? And the answer that I got was, well, we do everything here.
Well, that's probably, I'm only theorizing, perhaps that nurse is not very knowledgeable. She's not well experienced to understand that this particular case scenario needs to be placed in a specialty unit where that patient can be monitored, because it's
especially since when I came in, the patient wasn't intubated and needed to be intubated, and
it's
they
not
didn't notice,
the,
but yet they do everything there.
And it's not for the well-being of that nurse.
Right.
You should always be focusing on the patient's needs, and that's why I think we need to be more engaged with the decision-making over that patient. Sometimes your suggestions weigh a lot.
Right.
And it's not that you're challenging the administrators or the nursing supervisors, but we are independent practitioners. You have to look at things holistically, and medical conditions evolve minute by minute.
Right.
So you have to, and that's part of our assessment skill,
minute
to
by
be able
minute.
to pick up on these things.
Very good way of putting that. The second question and topic that we covered in my episode that I wanted to discuss with you was the union portion. Why nurses don't feel their unions are trustworthy or support them.
Well, I've spoken to a lot of union members. I am a member of a union, and
We won't mention that union.
yeah, I also
Right.
represent nurses, and a lot of the feedback that I get from the nurses is that some of the union reps are not knowledgeable about the union contract,
Okay.
labor issues. Secondly, a lot of nurses feel that when they fill out the protest of assignment forms, they may be grieving something. Later on, it gets to arbitration, and the union fails. The union cannot resolve the problem. It could be, again, it could be a patient ratio. It could be many different facets.
It could be, most of what I'm hearing, tell me if I'm wrong, is insubordination
Yes.
or a medication error.
Yes, yes. The nurse is challenged. The registered nurse, again, is challenged on the floor. So a case
right.
scenario, you may have, again, a nurse who is overwhelmed, and she has early, taking the assignment, told the nursing supervisor, I think this is dangerous. And then an incident may occur where the patient actually fell out of bed, or there was a miscalculation of a dosage, an interpretation of a doctor's order, and the nurse is always the one that gets the brunt of it. And I think it's important that the hospital
sure.
administrator is informed, as well as a nursing supervisor, that, again, when you do not have an adequate staffing,
Oh, yeah.
it's a given that you're going to have incidences like this.
Multiple incidents.
And then when
yeah.
the nurse is singled out and written up or reprimanded, and she's trying to defend her license,
Or
and
he.
she's told you early, give me the staffing that
I love to do
need.
that. Yeah.
And she winds up being fired or terminated.
Right. There's a lot of that going on. The cultural difference. Do you see any cultural difference in the civil advocacy, I call it, where we've learned through our civil rights from Martin Luther King to at least speak up for ourselves
Yes.
and to say,
Yes.
you know, as an American, I do know as a black American, I've learned, you know, through the works of Martin Luther King,
Yes.
Malcolm X. These were people that we looked up to that made us feel that we were heard. Al Sharpton.
Yes.
People like that. These people made us feel good. So we were able to say, you know, at some point, you know, I don't think I want to take that assignment. I mean, even the thought of it, you know, could be challenging. But we were able to do that and maybe go through an arbitration. Do you find any cultures in our field that won't